Hello, everyone, and welcome to the Down Syndrome Center of Western Pennsylvania podcast. As always, I'm your host, Dr. Kishore Vellody, and we are talking COVID today. And we know what that means. That means that our good friend of the podcast, Dr. Andy Nowalk, is joining us today. Andy, thank you so much for being on the podcast again.
I always enjoy the invitation, Kishore. And, I feel like I'm on a sitcom. I'm a recurring enough character now that, next season, I may want to be mentioned in the cast.
I think if we did have a rolling cast, like a roll of all the people involved, you would have to be right there at the top. I think I might put my mom and my dad, thanks to them. But then right after that, thanks to Andy Nowalk. So there you go.
Fine by me.
Yeah. Well, Andy, you might imagine that there is still this virus that people have questions about.
Unfortunately.
Yes. And they reach out to us quite a bit. And the news tends to generate some confusion in terms of what do these things mean. So before we get to some of those confusing parts, I was hoping you might be able to just give us, as you always do, like in your thought process, a general update to where we are in COVID in children at this point.
Sure. I think, Kishore, it's been probably a few months since we chatted. So, I think now of this pandemic as, first of all, we've just hit the year mark in our county, and the United States as a whole is at about the 13-month mark. So we've been dealing with this for a long time. We had an initial phase last spring and early summer where we had a big outbreak in a small number of areas in the United States, New York, Washington State, and had a relatively limited outbreak. At the time, if you recall, it felt very much like a huge outbreak, but boy, we didn't realize. The United States relaxed and people started seeing each other again, and mask discipline clearly fell off. So last summer, and early fall, we had another surge. And so that surge in cases, if you look at most of the charts from the CDC, was significantly bigger than the one in the spring. Now, people argue back and forth, well, we didn't have as accurate of testing in the spring. Right. Maybe we had that big of a surge in the spring, just didn't notice. That's certainly a possibility. What everyone agrees is that once we got over the summer surge, and really just we're struggling, I think, in terms of people being inside more, people being tired of wearing masks and being careful. And then holidays, Thanksgiving and Christmas, we had what we realize now is what a real surge of COVID could look like. So If you all look at the CDC website, we had a surge that cut across all ages. So we had a lot of cases in children finally. We had, 3,000 some deaths a day. We had 300,000 cases on many days, and we had just an incredible toll. The death toll to COVID in our country, the proven deaths, are at around 525,000 right now, which, just to give you a frame of reference, because we used to talk about flu seasons. Well, we left them behind. So This is now almost as deadly as the Civil War, which is the last really of similar size major amount of mortality of Americans. And remember, that took 4 years. A lot of it was infection and not battle. And then our next milestone that we're very likely to hit, unfortunately, will be the Spanish flu epidemic in 1918 to 1920, which took the lives of about 625,000 Americans. So, we're talking about staggering amounts of what is just tragedy with this.
Yes.
What we have learned, though, is what we knew before. There are not as many severe cases in children. Children get COVID, although especially the young children just don't get it as much as any other age group. And when they do get it, they tend to get a less severe form of it along the way. So, that much is certainly something that we have recognized has been a bit different, and something that's been very useful for us to reflect on along the way. That doesn't mean that it's been a benign disease in any of the people that we're talking about. I mean, we're really talking about, thousands and thousands and thousands of deaths in adults, but we've seen deaths in children. And then we've also seen this weird multi-system inflammatory disorder that you and I are still trying to figure out what it is and trying to get our head around it as well. So really just a tremendous amount of disease in the United States that has been challenging for us to work with.
And you were just talking about the CDC and looking at the website. One of the things that the CDC did come out with recently was this updated guideline on mask-free gatherings. And I know there's been a lot of confusion as to who that applies to. So could you help us understand this a little bit more?
So mask-free gatherings, the CDC, let's talk about vaccines first, because I think the last couple of times that we discussed things, we were on the edge of vaccination. And, now I could not be happier where we are with vaccines, because we are really bathing in vaccine. So today I just checked the CDC website. We're at 106 million Americans who've received at least one dose of vaccine. We gave 5 million doses in the last 2 days on the weekend in the United States. 5 million doses. Wow. That is getting close to 2% of the entire United States got vaccinated on Saturday and Sunday. So that is a tremendous, tremendous, tremendous good. When we look at this, obviously kids who are the least severe age group are the ones who've been vaccinated the least, because the vaccines are not actually licensed in them yet. So under age 16, no one can get it. And between 16 and 18, only Pfizer is licensed for delivery. Those studies are ongoing right now, and we hope to have the information from them in the next couple of months. Hopefully by the end of the spring, beginning of summer, we'll be able to get this
for the younger kids that you're talking about. Yeah.
Yep.
Okay.
Yep. But we've done a tremendous job in older people. Right now in the United States, roughly 2/3 of everybody over 65 has been vaccinated. Additionally, what we recognize is that we're doing really well and doing a fantastic job for folks who are in higher risk categories. So it's unfortunately, of course, because the US can be chaotic, different state to state. But in a number of states, like our own, folks in many risk groups have been classified as high risk, and Down syndrome is a very frequent risk group. That'll pertain to the paper that we're going to discuss later today. So, we're targeting a lot of folks. A lot of our older folks with Down syndrome are starting to get vaccine moving towards them. So there's lots of good things happening on the good fronts there. That leads me to masks and the information from the CDC. So the CDC has conceded with these vaccines, which have unbelievable efficacy, preventing 95% of symptomatic infections, that when you have lots of vaccinated people in the same place together, and none of them has acute symptoms of something, they can take their masks off if they're in the same place. If you know where they've been, if they're vaccinated and they don't have symptoms, it is safe for a family pod to eat together without masks. It's safe for grandma and grandpa who are vaccinated and careful about who they seek to come over and see the kids. So this is a wonderful thing. This is a beautiful thing. However, doesn't change the fact that if 65% of 65-year-olds are vaccinated, 35% are not. And I said 106 million Americans have received vaccine. Well, 244 million haven't. So that's more than 106. So we're still in a time where in other settings, when we're out in a public setting with lots of people around we don't know, if we are in schools and kids are coming together, if we're in the hospital, you and I still mask all the time. You and I are both unmasked right now because our doors are closed and there's nobody in our offices with us. And that's important. It's an important point. I wouldn't be doing the right thing for my colleagues if I did it any other way. When I walk out of here after this, I will put a mask on to protect everyone around me. So we still need to be vigilant. And I hate to say this, we need to be really vigilant about bars and restaurants still. We just need to be careful about those two settings, which still drive a lot of disease. However, I think the one thing that we need to do more than anything else, save masking, is to convince everyone we know who is between the age of 20 and 40 to take vaccine. Right now, that group is very laissez-faire about when they're available to get vaccine, whether they'll get it. If we can convince 2/3 of those folks, I don't need 90%, give me 2/3 of those folks, we could really make this epidemic ebb very dramatically.
Yeah, I agree. And there's this ongoing discussion in the media about the variants that are out there. And is all of this vaccination in the end? I've heard people say, well, what's the point of getting vaccinated if there's variants that are going to overcome the vaccine? What are your thoughts about these types of things?
So, boy, this is where you'll hear my constant complaint. I feel like the news media has been not necessarily our friend a lot. It's been our enemy sometimes. So here's what we know about variants. And, this is natural part of virology. People who study viruses aren't surprised by this. viruses mutate over time. We know this from the flu. You know, you and I have to get a different kind of flu shot each year to keep up with the variants of the flu. So this is the same thing with the COVID virus. There are horrible names. So there's the P1, the B117, the B this, the T that, the 3, 4, 5, 6, 7, 8, 9. I like to call them the UK variant because they identified one in the United Kingdom, the South African variant because it was identified in South Africa, and the Brazilian variant, which you'll be shocked to hear was discovered in Brazil. What do we know about all of these variants? They have a number of changes in them that theoretically mean that they would be less likely to be covered by vaccines and might be more contagious. There's theoretical risk that if they're more contagious, that maybe they'd be more lethal. So here's what we know in practice. We know that the United Kingdom has most of its virus now made up by the UK variant. And they have some concern that there has been a small increase, but a definable increase in the mortality rate from infections. However, it's still hard to sort that out from the increased number of cases that they're having. So it's plus minus on that variant. The South African variant seems to be a little bit more resistant to some of the therapies that involve antibodies before and a little bit more likely to cause reinfections. However, it doesn't seem that much more contagious, and it doesn't seem to be that much more lethal than anything else. The Brazilian variant is the one people are talking about a lot because it seems to be more contagious based on some studies and maybe causes more severe disease. But again, that data is very hard to sort out right now. What we do know in the United States right now is that we have a lot of variants in some places. So for example, California has a lot of variants. Florida has a lot of variants. So you would predict if there's a lot of variants, there should be cases going up in both of those places. Well, as it turns out, Florida has a slight increase in its cases and California's cases are going down. So what does that mean? Well, I don't know. You know, this is very early on with these variants, but in general, I am skeptical at saying that this is the end of humanity, which is something you read everywhere. The variants, there's some new data to suggest they provoke a good immune response that protects you against reinfection with them. It does seem like there is a risk that if you had a variant in your community and you were previously infected, especially infected way at the start of the pandemic, you might be at risk for reinfection. Is it going to be more severe? We don't know. But the suggestion is it's going to be less severe. So we need to get a lot more data on this. But I have to tell you that what I've read about them isn't as scary as I thought it would be when I heard initially. So what I'd say is stay calm. These variants are very contagious, just like COVID, and not dramatically tenfold more. These variants are going to make you sick just like COVID, but not dramatically more. And whether they cause more death in very elderly or susceptible populations, the jury is out. But really the message is the same. We just need to use the same things that work now that worked before and would work against any variant. The main question people have is vaccine. Yes. And so some laboratory studies have said the vaccines may not work as well against some of the variants. It turns out when we're getting these data that it looks like the Pfizer and Moderna vaccines, the most common ones in the United States, seem to work well against the UK variant, a little less well against the South African variant, and even less well against the Brazilian variant in laboratory studies. So those are people looking at Petri dishes and saying tenfold, fivefold, and making lots of judgments. We have no idea how that's going to work in the real world setting. So, you know, I would guess that the vaccines are going to do a little less well against some of the variants, but they all are going to have some activity, and particularly the Pfizer and Moderna vaccines, which is about 99% of the US vaccination so far, we think are going to work pretty well against at least two of them.
Okay. All right. So
remain calm. That's my message.
I'm remaining calm, and our listeners will now remain calm as well. And, you know, I think one of the things that our listeners should know is that when you're not doing podcasts with me, you are very active in research. And one of the areas where you have been working with is with a group called the T21RS. And maybe you could describe for us what that is. And then the study that just recently came out that I saw talking about COVID and Down syndrome. So kick it off for us.
So thank you for bringing that up, because I think that one thing I've done throughout my whole career that I'm very passionate about is the need for good research, whether that's basic science laboratory research or clinical research. The T21RS is a group of researchers around the world who are very interested in doing research on a number of topics on people with Down syndrome and doing everything from basic science research to clinical research and epidemiologic research. So I was actually approached by this group in the spring, based on some previous work I had done around infections in people with Down syndrome, to give them some advice and to participate in their design. It is an international group, which is very, very satisfying for me. It is a group that is really focused very heavily right now on trying to learn some things about COVID. And so I was part of the group that helped to design a survey that the group wanted to put together. You know, it's really hard to do a study where we get data from countries across the world and put that together around Down syndrome. And we recognize very quickly that many countries don't keep that data in organized fashion. And some, like sadly, the United States, don't collect it at all. Mm-hmm. So the group flipped to a different way of doing this. Let's go to the people we know. So we know lots of people who take care of patients with Down syndrome, and we know lots of families who have loved ones with Down syndrome. And let's ask them to give us information. So this is a very different way of gathering information, but a great way to get away from the barriers of finding that health data within big systems and to collect it more real time. And so the survey was developed in March and April of last year with this very international group to look at people with Down syndrome who were getting COVID and to study a lot of the things that we could extract about them, their demographics, their living situation, you know, whether they were at home or in a living facility, their pre-existing health conditions, how they presented and what happened to them. So a very straightforward survey design to try to accomplish that. And it was really intended to get a look very early on at what was going on. Because as you and I have talked about in some of the data we've discussed so far, that data has been very few and far between. And even small studies, you know, 4 individuals here, 12 individuals who went to Mount Sinai, get published, and they're lovely, but they're not very large in scope, and they don't give us the kind of information we would really, really hope to get along the way. So this study was done throughout last year and finally was released and published in the journal called eClinical Medicine in the last month. And I think it's a really interesting and useful set of a larger group of data to talk about people with Down syndrome and how they've been doing with COVID.
Mm-hmm. And what were some of the things that you guys uncovered were some of the major themes of this survey paper?
Well, you know, first of all, we were able to get about 1,000 surveys back on individuals. Yeah. So that was great. That, you know, as I just mentioned, we talked about small numbers, even in national surveys before. And so to get 1,000 pieces of information about individuals was really helpful to us. We got it from across the globe, but there's bias to the information. So, you know, about 1/3 of it was from India, which makes sense. You know, like 1/3 of the world's people are in India, so that's not inappropriate. About 15% from the US, about 15% from Spain, 10% from France, and then a number of other countries. So, you know, there are biases there. We don't have very many people from South America. Brazil was most significantly represented. Crushingly for me, we have very little from Africa. And that's very disappointing to me that we have so little from that continent. So these data look like those surveys. There are a lot of white and South Asian patients in it, a fair number of Latin Americans, and very few African Americans or Africans in the sample size. And then we had a nice spread of people who were living at home and living in facilities, depending on the survey type. And just to encapsulate what we learned, we confirmed a lot of things we knew already. So we confirmed things that you and I have talked about before. What we've always said on this podcast is the older you are, the worse you do with COVID. And that's true in regular people, and it's true in our loved ones with Down syndrome. So we found that the older you are, the much worse that you did. And consistent what we saw from that really nice UK study we discussed before, that older means different things for people with Down syndrome. So older in the United States, for example, means 65 and above. Older for our Down syndrome population moves back a little bit to the 45 and above. And, you know, we just don't have that many people who are above 75 with Down syndrome. So, you know, the disproportionate effects happen there. What we saw was some things that make perfect sense. You know, people with Down syndrome don't typically complain of changes in their smell compared to controls. That is not a surprise. I don't know if you guys have tried to communicate sometimes with your loved one with Down syndrome. My 15-year-old is not going to do anything significant about telling me things he doesn't smell. He will like to make a joke about stinky things he does smell. But, you know, it's harder communication-wise to get some of these symptoms. Like myalgias were less reported in people with Down syndrome. Not a surprise. Number one, our people have high pain tolerance. And number two, they may have trouble expressing. If you say, hey, Mr. Joe, you know, John Doe with Down syndrome, do you have myalgias? They may have a lot of trouble understanding that language. So not a surprise either. But very, very importantly, when they got into the hospital and when they got COVID as well, they were more likely to get pneumonia. They were more likely to do poorly with pneumonia. And they were more likely to die with pneumonia. 3 things we knew already from previous experience with pneumonia and Down syndrome, and 3 things that seem to be confirmed for COVID as well. So if your loved one with Down syndrome gets COVID, especially if they're older and have the same risk factors like obesity and diabetes, many others have, they're going to do poorly with it. And the quantification of that is challenging, but it does seem like people with Down syndrome, having Down syndrome puts them at significant increased risk for bad outcomes from COVID.
Okay. So it seems that this study, like you said, it confirms so much of what we know, and it confirms the importance of vaccination. And, you know, we do have folks who have adult loved ones with Down syndrome on this, who listen to this podcast. So questions that come up: should people with Down syndrome, when their time comes, get the vaccine, or would you have more hesitancy about recommending vaccine for somebody with Down syndrome?
So this is a great question, because we know that people with Down syndrome are in increased risk, number one. And number two, we know that they are often in places like care facilities that have had really, really big problems with COVID. And we know that that risk for them happens probably at an earlier age than it does for the general population. We also know that, you know, they tend to be more autoinflammatory. You know, autoimmune diseases are more common in this group. And so it's interesting to ask the question of, well, would that give me any hesitation? No hesitation whatsoever. We know that pneumonia kills people with Down syndrome, period. And we know that COVID in these older individuals is doing the same thing it does in older individuals without Down syndrome. So this is a high risk group that needs vaccine. And the great news is these vaccines work really well. And when we've looked at the post-licensure data, that is, when we've looked at the people who have gotten vaccine, who have pregnancies, who have autoimmune diseases and other disorders like that, they don't seem to be having increased side effects from the vaccine, and they do seem to be deriving lots of protection from the vaccine. I can't stress this enough. If you have a loved one who is 16 years or older and is able to get vaccine in your state, get vaccine. Okay. And if they're not, because they're not high priority, write your state senator or write your insurance commissioner or write your secretary of Department of Health and say, why the heck aren't they? You know, they should be prioritized across the country in the same way other high-risk groups like the elderly are prioritized, in the same way as other people with significant diseases like obesity or diabetes are prioritized.
I agree. And especially with the CDC statement clearly stating that people with Down syndrome should be considered high risk based on all of these studies that we've been talking about. Couldn't agree more. What about under 16? You were mentioning the studies that are ongoing. When do you think, in your best estimation, that children, including children with Down syndrome, might be able to get on this list of vaccine eligible people?
So that's a very, very interesting question. You know, I think we're going to get the data pretty soon. As I said, in a couple, 3 months. I think if you have someone 16 or over where Pfizer is licensed, I would get that. If you have someone who's under 16 and doesn't have any options, you know, the data's going to come quickly, because there's not the same level of evidence required now that there's emergency use for older people as there will be for younger people. As you're waiting, recognize again that cases of COVID are very common across the United States, but the least common group that they are found in is 0 to 4. 0 to 4 has really comprises only about 2% of all cases of COVID in the United States. It's a really underrepresented group. And when you look at the mortality in young children, in the entire pandemic reported to the CDC, under the age of 18, we have had less than 300 mortalities seen with COVID. Now that is a tragedy, every one of those 300 cases. But we don't have any data right now to suggest that there is a dramatic increased risk for people with Down syndrome, or that all of those are people with Down syndrome. And I can tell you, just as a sidebar, I started working with the CDC on putting this data together. And, we don't have anything organized or published yet, but the early look shows that people who are dying from COVID under the age of 18 are very, very varied in the initial look at the data. So it's not all people with Down syndrome, to reassure everyone out there. So, the fact that we need to wait is reasonable at this point, because we really want to protect our people with Down syndrome now by vaccinating everyone in their home. If you live with someone who has Down syndrome and they are under the age of 16, you are what they're relying on. Get vaccinated. A lot of states, Pennsylvania included, for example, will vaccinate caregivers for high-risk people. Take advantage of that.
Yeah. Wow, Andy, I feel like we have covered a ton in this podcast today. So I really appreciate you sharing your time and your expertise with us today. Anything that you would want to leave us with before I close out our podcast?
I'll leave you with a few things. Some of them are echoes of the pre-COVID podcast we did, right?
Yes.
Number one, get vaccinated. That's how we end this. I know all of us are tired, and all of us, many of us have lost people. All of us know someone who's lost someone, and we're really tired. So get vaccinated, because that's the way we get out of this, period. That's number one. Number two, don't stop masking and being smart. That's the second way we get out of this. If you're worried about the variants, the way we avoid them from becoming a big problem is we mask and we're careful. If you look very carefully, for example, at the variant data, there's a lot of hubbub about a report out of Brazil, about a town in Brazil, I think it's called Manaus, that had a huge outbreak. And, people were really worried about this signaling the variants out of control. Well, they had a huge outbreak just before the holidays when they were not really enforcing any restrictions. So It's not a surprise to me that they had a lot of infections in that respect. So people got to mask. It's very, very, very important. But then finally, I would say, as we're looking at this moving forward, the minute your kids get the opportunity and the availability of vaccine, vaccinate them as well. I have wondered a few times if I would try to tell my pediatrician, I know it's not licensed, just give it to my son. I'm not going to put that on him, but that's how passionately I feel that these are going to be safe, effective in children. I think that they're going to be the thing that gets us home. Vaccinate, vaccinate, vaccinate. We're almost there.
I agree. And now having two elderly parents and now my brother fully vaccinated now, it is such a joy to be able to see the light at the end of this tunnel. So thank you for sharing that with us today. And for our listeners, thank you so much for being so loyal. We are nearing 100,000 downloads of our podcast. This is not what I expected when we first started this podcast, but it's been a beautiful surprise. So please continue to send in your desired topics for us to cover. Down Syndrome Center at chp.edu. And also please stay tuned and listen to our next podcast, which will be a World Down Syndrome Day podcast with very special guests. I'm going to leave it at that. Very special guests who I've never had on the podcast, but I'll give you a hint. They are quite possibly the most important people in my life, and they want to share with you their experiences. And so listen to that coming up here in a few days. But until next time, bye-bye.